Professor Emeritus, Department of Cell SDMC ODP, to take for the session. Welcome, sir.
Now, the next is about the lymphomas. Now, lymphoma word suggests about many diseases. It's not a single disease, group of diseases, and which have different sorts of the nature of lesion, and there are different types of this prognosis also, as well as the pathology also different. But in general, to make it simplified and a bit earlier classification, is the lymphomas are classified mainly into two categories: Hodgkin lymphoma and non-Hodgkin lymphoma. Hodgkin lymphoma is about it's a majority of the patients, and about 85% of all malignant lymphomas are non-Hodgkin lymphomas. The median age of diagnosis is around 68 years. Burkitt lymphoma and lymphoblastic lymphoma occur at a younger age as such. Now, the classification of lymphoma itself is a very rather unstable issue. The classification has varied from year or maybe time to time. The initial classification was non-Hodgkin's and Hodgkin's. Now, then later on, based upon the type of the cell, it was again categorized. Non-Hodgkin was categorized into B cell and T cell type of lymphoma, and there again further classification also was done earlier into subclassifications based upon the microscopic and genetic character of the tissue, as well as the prognosis as such. And now the latest is about the WHO classification. WHO classification identifies around 20 varieties of these types of the lymphomas, non-Hodgkin lymphomas, and they are again very complicated issue. Further, I think that all that detail is not necessary from our basic classic point of view. Basic simple classification would be Hodgkin and non-Hodgkin. We will limit only to these. We will not go into all individual subclassification, because all these individual classification is based upon the genetic information, which is a very advanced issue. So that's about the basis of lymphomas. Now we will go a bit in detail about Hodgkin lymphoma. Hodgkin lymphoma is defined as a hematological disorder presenting with the Reed-Sternberg cell. The Reed-Sternberg cell is defined as a mirror image type of nuclei, a cell with the mirror image type of the nuclei, where there are two components of the nucleus, and it's a lymphoblastic origin from the lymphoblastic type as such. And in the WHO, it categorizes Hodgkin lymphoma as a classic or nodular or lymphocyte predominant, and the classic Hodgkin lymphoma again into four types as a nodular sclerosis, mixed cellularity, lymphocyte depleted, and lymphocyte rich. Now these are either types of the Hodgkin, or these the same also are considered as the stages of the Hodgkin disease. Now that Reed-Sternberg cell as such, Reed-Sternberg cell would have different types of the shapes, and based upon this, like either classic RS Reed-Sternberg cell or mononuclear variant of the Hodgkin cell, based upon these microscopic appearances, these are again subclassified further based upon the type of these Reed-Sternberg cells, either pleomorphic or lacunar or mummified. Now, Reed-Sternberg cells comprise only 1 to 2% of the total tumor cell mass, and the remainder is composed of a reactive, mixed or inflammatory cells consisting of lymphocytes. And hence, at one stage earlier, Hodgkin disease was also considered as a inflammatory disorder, not as a tumor pathology. But now that kind of a controversy doesn't exist as such. Incidence of the Hodgkin disease in 2018, the incidence is more in the Western countries. Comparatively, in India, the incidence is comparatively lesser. The global incidence of Hodgkin lymphoma is around this is in 2021. This data is 2022 data. 2022 data. 82,469 cases were reported all over the world, and the mortality is 22,736. That's a relatively high mortality in Hodgkin's lymphoma. The history of Hodgkin's lymphoma starts with the Thomas Hodgkin, who defined this disease, and Reed and Sternberg, the scientists who had identified the pathology, identified that type of the cell, and based upon in credit of their names, the cells are named as Reed-Sternberg cells. The Reed and Sternberg were two of the scientists who had defined the microscopic character of the cells. The etiological factors. Hodgkin disease is known to be present in patients who have a virus infection like Epstein-Barr virus infection, which is seen in around 30% of the cases. HIV positive patients also have higher incidence of the issue. That's about the viral origin. Another of the etiological theory is about the genetic predisposition. Certain genetic characters are supposed to make the person susceptible for Hodgkin disease, and this also tends to occur in the families as such. As far as the clinical symptoms of the Hodgkin disease are concerned, the most common clinical symptom of Hodgkin lymphoma is asymptomatic lymphadenopathy, where there would be no symptom of pain or any other feature. It's only the lymph node swollen. And the common type group of lymph nodes which are swollen would be in the cervical area, axilla, or the inguinal area. Cervical area is the most common area as such. And characteristically, the lymph nodes enlarged in case of Hodgkin disease would be symmetrical. When one lymph node is involved, the other side also, the lymph node on the other side also would be involved, and that symmetrical character is very characteristic, though it may not be seen in all 100% of the patients. Consistency of lymph nodes swollen in Hodgkin disease also is very characteristic, that is neither very hard nor very soft, and that's called as a rubbery consistency or Indian rubber consistency as such. So that kind of, and the surface would be smooth, and whenever if at all you open the tissue and look at the lymph node swollen due to the Hodgkin disease, the surface would be smooth, there will be no exudates, and that's how you make out the difference between the tubercular and the Hodgkin lymphoma. Tubercular lymph nodes, the surface would be, the capsule would be very thick, and the capsule would have a lot of exudates, thick exudates, vascular, whereas the lymph nodes of Hodgkin disease, they would have an extremely smooth surface, and there will be no evidence of hyperemia or increased circulation, and that's very characteristic of Hodgkin lymphoma. And majority of the patients would present with a lymph node swollen, and whenever there is a symmetrical lymph node swelling without any pain and having a rubbery consistency, it's almost a certain diagnosis of Hodgkin lymphoma. The other clinical symptoms which may occur in case of Hodgkin's condition would be unexplained weight loss or low-grade fever and night sweats. Presence of the fever or absence of the fever also is one of the criteria by which you grade the condition. When we go into the grading, we will come to that part. So patients who have no history of fever but Hodgkin's disease, that's graded as A category, whereas those who have a fever as a clinical symptom would have a categorized as a B category. In general, the course of the disease with the B category, having a fever, would be rapid, and the prognosis also is comparatively poorer. Whereas A category, where there is no fever, the outcome would be better. The other symptoms which can also occur could be chest pain. Chest pain usually because of the mediastinal lymph node enlargement, shortness of the breath. The other relatively less common clinical symptoms, those three are the more common clinical symptoms. The other clinical symptoms which can occur could be pruritus, itching, as a result of the lymphocytic infiltration, and that itching doesn't respond to the usual conventional treatment like antihistamines. Then pain at the nodal areas, at the areas of the node. Usually, most of the times, the lymph nodes are painless, but occasionally there could be some pain also. Pain in the bones, particularly back or bone pain, and whenever the pain occurs due to Hodgkin's disease, it's usually in the long bones and in the shaft of the bone, not at the epiphysis. The degenerative disease of the bones, they would produce the pain in the epiphyseal area, and a patient presenting with a pain in the shaft of the bone or a diaphysis area should always be considered cautiously. There could be plenty of other serious issues which can induce that pain in the shaft area, and one of that condition would be the Hodgkin disease. Then the patient also have a genetic predisposition, and there could be a history, a family history also. Then in the back of the throat, most of the times the swelling also would be involving back of the throat and posterior angle, triangle of the neck, or even the epitrochlear area, that's upper arm, the elbow area also, that's around the elbow. These are the other areas which could also be rarely involved in case of Hodgkin's disease. Splenomegaly or hepatomegaly and hepatomegaly, again only seen in a few patients, not all. They also can be a presenting symptom in Hodgkin's disease. Superior vena cava syndrome also may occur due to mediastinal lymphadenopathy. When the mediastinum is involved, there could be compression of the superior vena cava, and hence the patient may develop the edema in the lower limb. Hepatomegaly as a result of the vascular obstruction, even there could be ascites, and that's what we call as the superior vena cava syndrome. Central nervous systems of paraneoplastic syndromes like cerebellar degeneration, neuropathy, Guillain-Barré syndrome, or encephalopathy also may be the clinical symptoms, but they are very rare, not so common in case of Hodgkin's disease. Classification of the Hodgkin's disease is categorized as into 4 types. I think I have referred to that part. The WHO categorizes these as the types of the classic Hodgkin's disease, but from pathology point of view, it's categorized into 4 categories as nodular sclerosing Hodgkin lymphoma, which is also named, abbreviation is NSHL. It constitutes around 60 to 80% of the patients. Mixed cellular Hodgkin lymphoma, 15 to 30%. Lymphocyte depleted Hodgkin lymphoma, that's LDHL 1%. Lymphocyte rich classic Hodgkin lymphoma is 5%. Now all these classification is based upon the microscopic sub features only. Of late, very recently, there is another 5th subgroup added as a nodular lymphocytic Hodgkin lymphoma, which is around 5%, a distinct clinical entity which is not considered in the classic Hodgkin lymphoma. Anyway, that's about the advanced issues. Biomarkers which confirm the Hodgkin lymphoma are CD15 and CD30, and in the regular clinical practice, these are now used as one of the basic criteria or other additional criteria to make the diagnosis of Hodgkin lymphoma, and they are usually seen, these biomarkers are seen over the Reed-Sternberg cells. Then the other biomarkers are negative B cell markers like Hodgkin also are studied or used as the biomarker for Hodgkin. Serum biomarkers like serum TARC level, CD163 also is used, but more frequent are CD15 and CD30. The classification further, again there is a bit of this overlapping about the classification and the staging of Hodgkin lymphoma. Earlier classification in 1971, previously when during that earlier period, Hodgkin disease was being classified as in the stages as stage 1, 2, 3, 4, and the stages, what if there is a single lymph node in a single area, one single lymph node is involved, then that's considered as stage 1. If there are two or more lymph nodes which are on the same side of the diaphragm, that's either above the diaphragm or below the diaphragm, this is, if there is a single node, that is stage 1. If there are more than one lymph node but they are only on one side of the diaphragm, that's stage 2. And if there are lymph nodes which are swollen across the diaphragm, a few of the lymph nodes above the diaphragm, a few of the lymph nodes on the inferior part of the diaphragm, which suggests about a wider spread of the disease, that's considered stage 3. And stage 4 is where there is the involvement of other organs like the liver or maybe the intestines or rectum, etc. Then the presence of fever, night sweats and weight loss, that makes the condition as B, or I have referred to that part earlier, and those which do not have these symptoms are categorized A. So in every patient, when a patient comes to you, you will have stage 1 AB, stage 2 AB, or stage 3 AB, or stage 4 AB, depending upon the presentations. That's how the clinical staging is done. Investigations which are quite useful are chest X-ray, because the chances of mediastinal lymph node involvement are quite high, and mediastinal lymph node enlargement can be made out in the chest X-ray, and that's very classical. Uniform consistency of the lymph node involved in the mediastinum, producing compression of the middle mediastinal structures, comparatively less common pressure on the trachea. It may be producing more compression on the aorta and the esophagus. So that's how the symptoms would be developed in patients of Hodgkin's lymphoma. The same can be confirmed by either CT or MRI. The lymph node enlargement, their location and their pattern, surface characters, they can better measured with the CT or MRI. They are the classical investigations as such. Prognosis of Hodgkin lymphoma as a 5-year survival period based upon the stage conditions are: stage 1, if they are only in one layer of the cells, then the 92% survival period, 5-year survival period is possible, and stage 2 is 94.8%. Stage 3 is spread to regional lymph nodes, 87.1 5-year survival period. Stage 4th that has metastasized, still the prognosis is better, 5-year survival period is around 81.2, and unstaged, there are certain conditions where it may not be possible to make out, the could be the 82.6 as such. The prognosis of Hodgkin disease is based upon a classical procedure of International Prognostic System or IPS system, and this is based upon the calculation of the assigned points for each of the biological findings as well as the physical character or the nature of the patient. A male sex, there's a 1 point is added; female, there is no point as such. If the serum albumin level is less than 4 gram per 100 ml, then the point is given 1. Hemoglobin less than 10.5, 1 more point. Above 45 years or older, again 1 point added. If there is an above classification, that is stage 4th, where the lymph nodes are showing the depletion of lymph nodes or lymphatic cells, again 1 point added. WBC count greater than 15,000, again 1 more point added. And absolute deposit count less than 600, also the one is 1 point added. If there is no such prognostic factors, these are considered as prognostic factors. If none of these prognostic factors are seen, then the survival period would be 84%. The outcome would be better. More the prognostic factors numbers, 1 prognostic factor, it's 77%, 2 prognostic factors 67%, 3 prognostic factors 60%, and 5 or more prognostic factors, so 42% is the success rate. So prognosis is explained by that. The other factors which make the prognosis varying would be the bone marrow involvement in Hodgkin's occurs in 4 to 18% of the patients, and bone marrow involvement often occurs in immunodeficiency patients like elderly or HIV patients, and it indicates extremely poor prognosis. If there is an involvement of the bone marrow in Hodgkin's disease, which is usually a sign of very advanced condition and often occurs in the patients who have other morbidity, the suggests of prognosis, poor prognosis, and that can be made out better with the MRI, where in the MRI shadow the bone marrow abnormality, that irregular density of the bone marrow in the long bones, usually most commonly in the femur, that's how it's seen. And it's also the other factor, if there is an involvement of the bone marrow, the patient may be better treated with the stem cell transplant as a treatment. The treatment, otherwise the treatment protocol would be the general chemotherapy pattern. Most common factor would be either induction chemotherapy regimen in the early condition, salvage chemotherapy if the patient has very advanced condition and otherwise there is no chance of curing the patient, or radiation therapies in localized condition. These are the one of the option. Or the fourth option is the patient may have the stem cell transplantation in the patients who have bone marrow involvement. And the protocols, the chemotherapy protocols, again I think from our routine point of view, these are not necessary. but still the common protocols which are used are methylamine, vincristine, procarbazine and prednisolone (MOPP), or adriamycin, bleomycin, vinblastine and dacarbazine (ABBD) and so on. These are the different protocols, and selection of these protocols is based upon the genetic information and the time to time developed guidelines. These guidelines are modified, so I will not go into that detail of the guidelines. But in general, outcome of Hodgkin's lymphoma is somewhat better than the non-Hodgkin's lymphoma. Now, the next variety is the non-Hodgkin's lymphoma. This kind of a classification of non-Hodgkin lymphoma was actually initiated in 1982. Earlier, it was just named as a variant of lymphoma, Hodgkin lymphoma, and so on. There was a bit of confusion. But this was very classically classified, defined in 1982, and based upon the morphology and the clinical outcome of the diseases. And in 1990, they revised this nomenclature or classification. They based upon immunophenotypic and genetic characters were identified. WHO, again, there are a lot of confusing issues about this classification. WHO has classification further elaborates into the very more detailed based upon immunohistochemistry findings as well as the microscopic findings, and it divides into mainly B cell and T cell and natural killer type of the origins, that mainly three. Then there are some sub varieties which also would be around counting to around 30 varieties of the non-Hodgkin lymphoma. We will not go into all that details. Almost 80% of the non-Hodgkin lymphoma are B cell origin, and only 15% are derived by the natural killer cells, and the others are mainly macrophages. Now, the classification of non-Hodgkin lymphoma, the very selected common entities are either based upon precursor B cells, acute lymphoblastic lymphoma, or peripheral B cell lymphoma, among them lymphocytic lymphoma, mantle cell lymphoma, follicular lymphoma, and so on. Precursor T cell, acute lymphoblastic lymphoma, peripheral T cell anaplastic lymphoma, and so on. So that's about the other types. As far as the common, very common, regularly used clinical type are anaplastic large cell lymphoma, follicular lymphoma, B cell lymphoma, diffuse large cell lymphoma, diffuse mixed lymphoma, lymphoblastic lymphoma, or mantle cell lymphoma, or mycosis fungoides, or primary CNS lymphoma, or cutaneous T cell lymphoma. Now, this kind of differentiation is also somewhat beyond the usual regular practice. The clinical grades, sorry, there was a spelling error. It's a clinical grades are categorized as low grade and high grade based upon the outcome. And most of the times, from the clinical point of view, this low grade and high grade classification would be good enough. The etiological factors for the non-Hodgkin lymphoma are one is chromosomal translocations, abnormality of the chromosome, and abnormality of the chromosomes do occur due to many key reasons. One of the common reason is radiation exposure. The other is the genetic predisposition. It also can occur as a complication of drugs or therapies which may affect the genetic composition. So, identification of the chromosomes abnormality is also one of the usual investigations in case of the lymphoma conditions. Patients who have some other infections also they may prone to develop non-Hodgkin lymphoma. Chronic infections, particularly fungal infections. Environmental factors. Now, there are a lot of factors related to environmental issues like the pollution and particularly the particulate substances in the air breathed in, the solid particles present in the air. Now they are counted or they are given in numbers as such, 200, 300 and so on, and based upon that the precautions are taken to avoid the pollution effect. Now that's also called as air quality index, AQI. Now these days it has become a rather popular issue. I think every day you see it in the newspaper, like in the Delhi's AQI numbers and so on. The persons who are exposed to the AQI of more than 300 ppm, they have a higher incidence of developing this lymphoma as such. Then patients who have immunodeficiency conditions also have higher incidence of non-Hodgkin's lymphoma. Chronic inflammation of any sort is also considered. Then the estimated age and the mortality rate, comparatively in India it is lesser, whereas non-Hodgkin's lymphoma is maximum among the major countries in Israel. Now, so from our point of view, compared to other countries, incidence of non-Hodgkin lymphoma in India is lesser. But still, we may get a few patients in the clinical practice, and so you should be knowing about it. The clinical presentation of non-Hodgkin lymphoma, again, the low grade clinical presentation would be based upon two of the categories, low grade and high grade. So I will not go into all that, the more detailed 20 or 30 varieties. We will limit only to that basic clinical parameters, so that the whole subject is somewhat simplified. The most common clinical presentation are a patient having fatigue and weakness, which are vague symptoms. So patient presenting fatigue and weakness, they should be examined thoroughly. And in such conditions, one of the signs which could be leading to the suspicion of lymphoma would be lymphadenopathy, peripheral adenopathy, like the presence of swellings in the periphery. It can occur anywhere, but again the most common sites are the axilla and the neck. Supraclavicular and the axillary lymph nodes are more commonly involved in non-Hodgkin lymphoma. Then of course the others also could be involved, and as in case of Hodgkin's, here also the prognosis is based upon the widespread that spread of the tumors, spread of the lymph nodes involved, and the consistency in case of non-Hodgkin lymphoma may not be the same way as that of Hodgkin. Hodgkin is typically rubbery consistency, whereas it could be of different grades. Harder the lymph node swelling, the more higher grade would be assigned to the non-Hodgkin lymphoma. So mainly it's about the lymph nodes enlarged in case of Hodgkin lymphoma, and because of that it may often produce some confusion with some inflammatory disorder. Unlike that of the Hodgkin's lymphoma, non-Hodgkin's lymphoma may not have symmetrical distribution. It could be often asymmetrical. Then extranodal symptoms other than that of the lymph nodes are temperature of more than 38 degrees centigrade, weight loss in large number of patients, around 10%, rather weight loss of more than 10% from the baseline in 6 months. If a patient has a weight loss of more than 10% in the last 6 months, then you have to suspect the possibility of a lymphoma. Or though they are common presentation, but they are not. They are common in patients with advanced malignant transformation when it evolves from low grade to high grade, or end stage disease. Bone marrow is frequently involved and may be associated with cytopenia. The total WBC count could be lesser. Intermediate and high grade lymphomas, the clinical presentation in the intermediate lymphoma, there will be lymphadenopathy, and more than 1/3 of the patients may present with the external involvement like gastrointestinal tract symptoms, involvement of that Waldeyer ring or throat lymph nodes, involvement of the skin or the bone marrow, genitourinary tract infections, involvement of the thyroid, CNS, and B symptoms like fever, weight loss, night sweats, they also occur in 30 to 40% of the patients. Then high grade lymphoma or lymphoblastic leukemia, lymphoblastic lymphomas, they are present with the mediastinal mass, and which could be both on the anterior and superior mediastinal plane, and hence they may produce the compression of the vena cava as well as the respiratory tract, the trachea. Or the patient may produce the compression of cranial nerves, and hence may present with the cranial nerve palsy. Particularly patients with Burkitt lymphoma often present with a large abdominal mass, and bowel obstruction, intestinal obstruction could occur, or even they may also have hydronephrosis due to the obstruction. That bulk of the lymph node itself producing compression, either it may produce obstruction in the intestines or obstruction to the flow of urine in the urinary system, and hence the patient may have hydronephrosis. And the primary CNS lymphomas, it's rare conditions, they may present with the symptoms of cortical irritation or space occupying lesion in the cranium, where the patient may have headache and vomiting. Large lymphomas also are the immunoblastomas, and they constitute around 1% of the intracranial neoplasms. Patients having tumor in the within the cranium, 1% are usually lymphomas, and they are common in patients who are immunodeficient patients, and this is also called as a Wiskow-Pardish syndrome, or after the transplantation, HIV-associated conditions. These are the common issues. The skin lesions of the lymphoma are very characteristic, and they are of mainly 5 categories: either pink or red patches, reddish patches with comparatively low itching, but when you palpate the surface may be rough, or a raised dark thickened patches which again would have lesser itching, or there could be raised thickened patches like plaques, which often produce some confusion with the psoriatic lesions often clinically, but unlike psoriasis, it may not be presented in the classical areas of psoriasis like the flexure surface of the forearm, behind the pin of the ear. That kind of a distribution is not seen. Instead, they are more common in the folds of the skin like axilla or in the inguinal area, and that's how the whole presentation would occur. Or light spots, that there could be hypopigmentary spots with somewhat raised surface, or a typically firm nodular lesions also could be seen. Among the patients whom we see with the non-Hodgkin lymphoma, the skin lesions of nodular types are more common than the others. That's what we see in routine conditions. The complications of non-Hodgkin lymphoma are mainly the cytopenia. The total WBC count would be reduced, as well as it may produce a reduction or reduce cells, platelet count, as well as RBC count. As a result of that, the patient would have hemolytic anemia-like symptoms, or deficiency of the thrombocytes may result in intravascular coagulation, or maybe bleeding disorders could occur, or infection due to the leukopenia, the particular neutropenia. So one set of the symptoms are the complications of the cytopenia. The WBC count reduced could be one of the set of the complications of the non-Hodgkin lymphoma. The others could be cardiac problems secondary to pericardial effusion or arrhythmias, also can occur due to cardiac metastasis. Respiratory symptoms may occur due to pleural effusion or the mediastinal mass, like superior vena cava syndrome due to the mediastinal mass as such. Spinal cord compression due to vertebral metastasis. Secondaries in the vertebrae also are frequently occurring in case of lymphomas. Neurogenic problems secondary to primary CNS lymphoma also can occur, like meningitis, present with the symptoms of meningitis. Gastrointestinal tract obstruction or perforation and bleeding from a gastrointestinal lymphoma also may occur either during therapy, chemotherapy also. Pain or leukocytosis also may occur in a patient with the leukemic phases. Investigations which may help in making the diagnosis of lymphoma are anemia secondary to bone marrow infiltration, and autoimmune hemolysis in mainly small lymphocytic lymphoma or SSL, or chronic lymphocytic leukemia, bleeding anemia or chronic disease. Then thrombocytopenia, leukopenia, pancytopenia, which can be made out with the peripheral blood picture. Lymphocytosis occasionally may occur with the malignant forms in low-grade type of lymphomas. Thrombocytosis, increased number of thrombocytes or platelets also could occur as a paraneoplastic syndrome. So the clinical picture, blood picture could be quite varied. More reliable investigation would be elevated LDH, lactate dehydrogenase level, that suggests about poor prognosis also, and abnormal liver function test results secondary to hepatic involvement also are suggestive of poor prognosis. Hypercalcemia, that's very common in acute form of T-cell lymphoma leukemia as such. The total calcium level would be raised. Of course, the investigations which are suggested are chest X-ray, bone scan, or gallium-67 study to make out the changes in the bone and bone marrow. Chest X-ray also may help in making out the lymph nodes as such, but lymph nodes of non-Hodgkin lymphoma are asymmetrical and they are having a irregular consistency, whereas a Hodgkin's lymphoma they are symmetrical, producing that bulging on both the sides. That's how we make out. Bone scan may show the presence of the bone marrow depletion changes. Gallium 67 again confirms that changes in the bone marrow. The stages of lymph nodes again almost on the same line as that of the Hodgkin's lymphoma. Single node on or adjacent groups of lymph nodes, multiple lymph nodes on the same side of the diaphragm. Stage 2. Stage 3 is multiple lymph nodes on either same side or it's also called as a bulky disease. Stage 2 bulky, that is when it's on the same side and they are also large in number. Multiple lymph nodes on both sides of the diaphragm, stage 3 as in case of Hodgkin's, and stage 4 is multiple extranodal involvement. Risk prediction, again the International Prognostic Index also holds good in the risk prediction of non-Hodgkin lymphoma. There again the risk factors are age above 60 years, LDH level being raised, stage 3 or 4th disease, or ECOG performance status, that's another criteria, that's Eastern Cooperative Oncology Group performance status, that based upon the outcome of the treatment. Then extranodal sites, that gives you the number, and if the risk factors are 0 to 1, the survival rate is around 75%. When the risk factors are 4 to 5, survival rate is 25%. Treatment is primarily the chemotherapy, infusional chemotherapy of cyclophosphamide, doxorubicin, or growth factor support. Granulocyte colony stimulating factors also are now being used as the standard line of treatment, which is very costly treatment now. And treatment of non-Hodgkin lymphoma varies greatly depending upon the tumor size, the type of the cell, histology, symptoms, and the performance status, patient's age and comorbidities. And hence, you may not suggest a single type of the drug. The group selection of the drug is again based upon the guidelines which are changing rapidly. With this, we will conclude the lymphomas as such. In the next, we will discuss about myeloma, multiple myeloma. If there are any questions, we will wind up today.